Good evening, everybody, and welcome to today's evening webinar brought to you by the Orthopedic Research and Education Foundation India through OrthoTV. And today we have the pleasure of having Dr. Vikas Agashe from Hinduja Hospital, and he's been on this webinar many times, so I'm not going to waste more time with introductions. So over to you, Vikas, and it's going to be some interactive case discussions on some interesting
That's right.
cases.
That's right.
Yeah.
Thank you, Dr. John and Dr. Janki. So let's start with the first case. I request all the participants to start their videos. Please start your videos because you're going to have an interactive session.
Yes. Yes, Subhanshu and Rajan.
Yes, sir. Open karna.
Okay. Can you see my presentation?
Not
No,
yet.
Right, sir.
Not yet.
Please share. अभी शेयर नहीं हुआ है सर.
नहीं हो गया है. अभी हो गया?
Yes, sir.
Yeah.
Yes, sir.
Just need to make it full screen.
Yeah. Okay. Chalo, shall we start? We have Rajan, Rai, and we have Subbu.
Sir, yes, sir. Subhanshu, sir.
Good evening, sir.
Subhanshu,
Good evening,
sorry.
sir.
Subhanshu.
No, sir.
Okay. So we'll start with a common exam case. So this is a 60-year-old man, has a discharging sinus here in the mid leg anteriorly or medially, you can say, of about 3 months. He is walking with a walker. At the moment, when he presented, he was febrile, no pain, tenderness, or obvious signs of inflammation. WBC, ESR, CRP were normal. And this is, I traced the old x-rays. He had RTA 6 months ago. You can see he has a segmental fracture. And then open reduction and plating with bone substitutes were done. And in about 8 weeks' time, he developed discharging sinus. He's on multiple antibiotics since then, but the sinus is persistent. And this is how he presented. You can see there's a sinus. That's the adherent skin, mainly in the proximal part of the incision. He carried a culture report from a swab taken 6 months ago. He's on cefixime and linezolid for 6 weeks, but the sinus is persistent. So what is your diagnosis? What would you call this condition?
So who's answering this? Rajan?
Chronic osteomyelitis.
Okay. Little more specific.
What kind of osteomyelitis? And why do you say it's osteomyelitis and not just infection?
Sir, the infection is persisting. That means there is a biofilm formation on the implants.
How do you know that there is biofilm formation?
Uh,
So why do you see any changes in the x-rays which suggest osteomyelitis?
there is persistent. There is discharging sinus, sir.
That means infection. I'm not.
Yes, sir.
denying it.
Infection, sir.
But how do you know it's osteomyelitis?
So we have to look for sequestrum in the X-ray or any bony spicules discharging from the sinus.
Yes, sir.
Multiple signs, but do you see anything that?
Yes,
will
sir.
make it-
Multiple cloaca is present in the tibia.
Multiple cloaca.
Like
Okay,
this lytic lesions.
What?
So can you point out a cloaca?
Well, I'll magnify the. Forget this. I'll magnify the film. Okay. Now, can you see?
Sir, this
I have magnified. I have magnified. So you think that is the cloaca?
The lytic lesion, it's not.
Do you think that this is a lytic lesion? Is there a lytic lesion in this?
So what do
No,
you
sir.
see on the X-rays? You see multiple holes in the bone.
Multiple holes, sir.
So what do you think that is from?
Sir, during the insertion of the this plate, they did the multiple holing and first
Why?
thing.
Why?
So maybe to drain the pus out of the.
So there was pus already there when they did the operation. I want you guys to start thinking when you answer rather than just saying something and then thinking, huh? Start trying to think before you answer a question.
So possibly they have tried to put plate there. Possibly.
Yeah, maybe they just
Okay.
tried to put. Yeah.
Barabar ki nahi? And they were not happy. Barabar?
Yes,
Yes, sir.
Can you see an osteolytic area here? Can you see an osteolytic area here? I purposely magnified this.
Yeah, where the screw is. Below
Can
the
you see
fracture.
the, again, now, can you see an osteolytic area?
yes.
Yes, sir.
So what is the other thing that is very obvious in the X-ray? You saw the first X-ray and you saw the X-ray now. Can we go back to the last film? So the last on, so the laterals, can you see anything on the laterals? What's that piece of bone there in front of the plate, upper plate?
Dead bone.
So now you see that.
Yes.
Did you see the first X-ray?
This thing.
First X-ray before the one that Vikas brought out for you.
Yes, sir. That with the discharging sinus with skin intact. No, X,
No.
sir.
Original X-ray, the fracture X-ray.
The very first X-ray.
X.
I will go back.
Yeah. Do you
Can
see
you
that
see
piece
this?
of? So what do you
Yes.
think? You think that bone has any vascularity in it?
And
The cortical fragment, most
yes.
likely without any attachment. And once you have infection, that's going to continue with, it's never going to let the
Barabar.
infection heal. Huh?
Now see this. Barabar. Can you see that? What
Yes, sir.
else do you see? What else do you see in
Else you see?
this? What else do you see in this?
Do you see any callus?
Yes, sir.
Yes, sir.
Do you think that is useful callus or infection callus?
So I have marked these with some with red arrows, some with green arrows. कुछ वजह है?
Sir,
Where is this periosteal reaction located? See this. You see my arrow, apna cursor?
Pointer, yes.
Yeah. So this is away from fracture site, correct?
Correct.
Barabar? Away from fracture site. So this is, what is this likely to be? What is this likely to be?
I can hear the cogs turning, but I can't see you thinking. I can hear the cogs. So we've just talked about it. What do you think? It's away from the fracture. Why do you get callus away from the fracture? It's a reaction. Okay. The reaction to what? Periosteal reaction to what? Possible infection. Okay.
Sir. Yes, sir.
Okay. Then see this. Can you see this?
Yes, sir.
Whatever. There's a osteolytic area there. Now compare that with this periosteal reaction. It is not fluffy like the other periosteal reaction, and it's going up to the fracture site. Right? Similarly here, there is a periosteal reaction here. Correct?
Yes, sir.
So there is a periosteal reaction near the fracture going into the fracture site, while there are some areas where there is periosteal reaction which is away from fracture site. So what is the significance of these two? What is the significance of these two?
So the periosteal reaction away from the fracture site denotes there is some infection.
Correct. Absolutely right. And here at the fracture site?
That's for fracture healing. Normal
Perfect.
colors.
Perfect. So if you notice, it's a very fluffy periosteal reaction. Barabar? While here it is something like a relatively solid periosteal reaction. Correct? So you can think that means the lower fracture seems to be healing or has healed. This fracture also partially it has healed. Correct? Now what is this? थोड़ा ऐसा a little hyperintense, बराबर? Little sclerotic, irregular, probably sequestrum, right?
Yes,
Let's see osteolytic area. This is probably sequestrum, right? So lesson number 1, always zoom in the X-rays. If you have digital films, do not see it on the viewing box only. See it on the screen and zoom the X-rays. That is the most important thing. Then take multiple views and always compare the X-rays that were taken prior to this film. Correct? 3 very, very important things. So finally, what do we have? We have infection, correct? Then we have recurvatum and possibly in non-union, possibly united, correct? Barabar?
yes, sir.
And the distal thing is there is minimal recurvatum, fibula is intact and is probably united, correct? Barabar ki nahi?
Yes, sir.
So we have a situation where we have a discharging sinus, we have 2 plates, the proximal fragment is probably, not probably, appears to be infected, but probably somewhere it has healed, while distal fragment does not appear to be infected, the distal fracture site, and is probably united. And we have a discharging sinus. Correct? So, abhi kya karoge? How do you assess this particular situation? So, think of host status, that is middle age and diabetes. Implant, we have 2 plates done 6 months ago. State of the fracture is segmental. Alignment may be accepted, may not be accepted. Proximal fracture is in non-union. Distal is probably united. Location is the leg with poor soft tissue cover. Consolidation, probably distally we have consolidation. Defect, it is impossible to make out unless you operate. Barabar ki nahi? You can't anticipate defect in this case, but likely in proximal fracture. And then you have a microbiology which is reported as methicillin sensitive. Now, is this I think we have done this earlier, but let me again ask you, is this MSSA or MRSA
Or something else.
or something else?
Insensitive.
Is it methicillin sensitive or methicillin resistant, or it has no relation to methicillin because methicillin does not appear here? Barabar ki nahi? There is no mention of methicillin here. Correct? Bolo.
Beta-lactam positive.
But their beta-lactam is positive too.
Beta-lactam is positive. So what does that mean? What does that mean? You see beta-lactamase or you see something else? What are the, in Staphylococcus aureus, what are the things that you have to see? There are three things you have to see. One is this cefoxitin screen.
Oh.
You have to see the cefoxitin screen. You have to see cloxacillin or oxacillin.
Oxacillin.
Okay? Because that represents methicillin. And third is you have to see this clindamycin, inducible clindamycin resistance. Okay? Has anybody heard what is cefoxitin?
Cephalosporins.
The second generation.
What is cefoxitin screen?
So it is a surrogate marker for
So in simple words, I'll tell you, cefoxitin wakes up sleeping MRSA, methicillin resistant Staphylococcus aureus. It wakes up because in a colony of MSSA and MRSA, very often only MSSA is picked up and MRSA may not be picked up. So that is why cefoxitin screen is done, which activate MRSA and then they become positive. So any lab which does not give you this cefoxitin screen is not to be believed. Okay? Oxacillin and cloxacillin are surrogate markers of methicillin. And what is this inducible clindamycin resistance? So this also you have to see when erythrocin is resistant. When there is resistance to erythrocin, you are very likely to give clindamycin, but clindamycin may appear sensitive. But generally a disc of erythrocin is kept next to clindamycin, and this is called inducible clindamycin resistance because erythrocin induces the proper resistance of clindamycin. So unless you do that test, what is called D test, you cannot start clindamycin. Again, in a case where erythrocin is resistant and or there is resistance to erythrocin and clindamycin test is not done, you cannot start clindamycin. Okay, so in short, we have MSSA. Now what should I do? He is already on chalu? He is on cefotaxin and linezolid. So since he is not settling, what should we do? Should we increase the antibiotics? Should I repeat the swab and then start antibiotic? Should I immediately do surgery or I do surgery after antibiotic free period? What should I do? Bolo, should I increase the antibiotics?
I will go for surgeries.
Straight
You will
away.
go for surgery when? आज कल परसों.
Immediately or after antibiotic free period.
After free
दो
period.
choices में.
और पेशेंट ने पैसा जमा किया उसके बाद.
You got the choices there, so choose.
COD.
Vikas has made it easy for you guys.
Yes, Adish.
I will raise up the antibiotics, sir.
You will
Higher
Raise the end. Higher
raise the
antibiotic.
antibiotic. Okay.
Sir, higher antibiotics. And
I
then I
would
will
do-
wait if I will wait and if that responds. If that doesn't respond, then I will go for surgery.
So what have you seen on the X-rays? You've seen screws which have lytic areas around them.
Yes, sir.
You are suspecting a sequestrum,
Yes, sir.
and then why will you raise antibiotics and hope that it will cure it?
Sir, immediate surgery.
Why
immediate surgery. Why would you do that?
Is he in septicemia? Is he going into shock because of infection?
No, sir.
But I think we've discussed this so many times. I'm surprised you guys still have to think about it.
So generally, when the patient is stable, it is safer in this such a chronic condition, of course, to wait for a couple of weeks, maybe 3 weeks, and then explore him so that you get appropriate culture.
You need to stop
Okay.
the antibiotics, okay?
You stop antibiotic with antibiotic-free period. Now that does not mean that you tell the patient कि अभी बंद करो and come back after 3 weeks. You have to put it on paper that for surgery we have discontinued antibiotics. However, if patient starts running fever, starts getting lot of pain, lot of discharge, and the whole thing swells up or becomes red, then they have to report immediately. बराबर कि नहीं? You can't just say कि अभी 3 हफ्ते के बाद आ जाओ. So in case it deteriorates, you have to open, but otherwise we would wait for about 3 weeks, correct?
So is this time 3 weeks or 2 weeks or?
So that's a very, very vague thing. 2 to 3 weeks. But what I generally do is if the patient has been operated multiple times without a culture report, then I would wait for 3 weeks. What is this thing you follow?
We do 2 weeks, but
Acha.
I'm not sure what the actual, is there a present
Yeah.
guidance
Keep-
on that?
People keep saying 2 to 3 weeks.
Okay.
So as I said, if he is operated multiple times and with negative culture, then I would wait for 3 weeks. Because you are just desperate to have a culture. But otherwise, 2 weeks. Okay, now what would be your strategy? You do there debridement, antibiotics and implant retention, or you will remove plates, or you will remove the upper plate, keep the lower plate, or you will remove the lower plate and keep the upper plate.
Sir, remove the plate, debridement, remove the plate, and
And
And sir,
give a
is
broad spectrum antibiotic and wait for. अच्छा नहीं कल्चर है हमारे पास सर एंड स्टार्ट द कल्चर एंटीबायोटिक
कल्चर है आपके पास? कौन सा कल्चर है आपके पास?
सर अभी सर ने दिखाया और
वो कब का है? आप सुन रहे हैं? You're listening to what is being said or not?
आई एम यस सर
When was that culture done?
सर वो नहीं
वो
I
नहीं देखा.
didn't.
okay.
Or even if it was done straight away, would you rely on that? Because it's a
No,
wound swab culture.
no, I send the again the culture and start
But
the
that will be at
antibiotic.
surgery, na? That you'll send the culture at surgery. Na? So you don't have the report of that.
That's the then broad spectrum antibiotics, sir.
Initially broad spectrum, and then you will do narrow down your spectrum once you have the culture, correct?
So
Correct.
what are,
Yes,
what
sir.
are your principles of treating infection?
We have to focus on the organism which is present in the infection.
Yes,
For
so
which
that,
the antibiotic is working on the bacteria. We have to give that
so
antibiotic.
that's one part of it. What are the other important parts of it? Debridement, that's the first and most important
Yes, sir.
part.
Debridement.
Then what?
The
Send the
for
culture and regularly monitor the ESR and
ESR.
CRP, sir.
Then what?
And again debridement if there is continue.
So you would also look at the stability of the situation. Huh? So
Yes,
if
sir.
it's a grossly unstable situation, personally, I would stabilize it.
These
I
are-
think Vikas sometimes tends to not do it, but I personally feel that stability is important. Of course, where you have a lot of fibrous tissue, there may be adequate stability where you can treat it in a cast. But if you have any doubts, for me, it's stabilization. Now, how you stabilize it would depend on you, okay?
Okay.
Then
Okay.
dead space management, yeah? Those are the important things that you need to have clearly in your mind when you're managing these patients. Huh? Because
Okay.
any dead space
So,
becomes a focus of infection.
so the first thing is create an uninfected envelope of soft tissues. What is called an orthoplastic approach, which needs good debridement to create a defect, create a clean defect, and then cover it, correct? And then stability to maintain length, alignment, and rotation. And then, of course, we have to add or generate bone. This is the basic principle, correct? Now, now let's talk of incision. What incision will you take? Will you take a straight incision like this? Will you take an incision like this? Will you take an incision like this? Totally disregarding the sinus, or you will do something else. Now, one by one, you can draw on this, annotate करके, draw on the fourth option. How will you take the incision?
Yes, Sachin, शुरू करो.
A, B, C, or something else.
Sir, option B, sir. We do
Option
option
B.
Yes, sir.
Okay.
Yes, sir.
Sorry?
Anybody with a different opinion? ये किसने
I
निकाला?
will take the whole इसका मतलब fibrous tissue and sinus within my next incision.
Great. Very nice. So
you-
whatever.
You saw the incision that was drawn initially, yeah? In the presentation.
I had drawn that?
Yeah, if you go back
एक
to
slide
your
में था सर.
first.
अच्छा. No, but let us give him credit here. Subbu, very nice.
So at least he's paying attention to that.
Good, good.
No, sir.
Very
Yes,
nice.
yes.
Absolutely right. So you excise it. Now, how do you carry the incision? Now, this is the anterior medial aspect of tibia, correct? What would be the direction of your knife and till what level will you go?
Through the bone, sir. Not मतलब it is subcutaneous plane, sir.
Subcutaneous.
So you will
No.
take out the subcutaneous tissue and skin.
Sir, this side is medial now, the sinus part.
Yes, this is medial. This is medial.
Just you gave the right answer and then you changed it, yeah?
Yes, sir.
So what was the right answer?
तुमने दो चीज
Actually,
बोला, एक तो
in the end, we have to cover
You
the
sign.
bone for the closure.
We're talking about the
So,
incision, okay? So where will your incision be? How will you make your incision?
sorry, sir, matlab,
So you have an adherent scar, correct? Which is stuck to the bone. Barabar? So what will you do? What will you do? You'll take out whole thing, isn't it?
end block. We have to
End
remove
block.
end block.
Absolutely. So you will not dissect at subcutaneous level, but you will go right onto the bone and take out everything, correct? So you will go right onto the bone and take out everything, including the sinus.
Yes, sir. Yes.
Now this is what I have found. Okay. This is what I have found. That's the lower plate, that's the upper plate. Now do I take out the plates or keep them?
I take out the plate. Yes.
Sir, it's depend the stability of the bone, whether we should take out or retain the plates.
Okay. So in case it is not stable, you will like to keep it?
No, sir.
If it is stable, will you keep it?
No, sir.
No, sir.
If the infection is
So
earlier,
if it is stable or unstable, you're going to take it out, right?
Right.
Barabar? Correct.
Yes.
So you're bound to take it out because that decision you have already taken. Na? There is significant infection there. Barabar? You will not be able to debride. So see this. Can you see this glistening layer?
Blackish.
sir.
Yes.
Correct? So that's something like biofilm, isn't it?
yes,
So you take out that layer and this is what you see. Now what would you do? Now what will you do? You will put vac, you will try to close, what will you do?
Sir, biofilm is difficult to treat, sir. So,
if
So what do you mean you treat the biofilm?
no, matlab, remove all the biofilms as much as possible. Close the wound, start the antibiotic, stabilize the this fracture, and
So can you close this wound?
no, the wound is not approximate, so we do vac dressing most probably for few days.
How many days?
So as the situation that the infection subsided or not, infection free days are present or not.
So friends, we have already discussed the X-rays in detail. Correct?
Mm.
There is an osteolytic area. There is a sequestrum.
Yeah,
Now that you
debridement
have
is
to
over.
find. Barabar ki nahi? That you have to find. Unless you do that, your infection is not going to come under control. So you can't be happy at this stage. Barabar ki nahi? Try and trace the fracture site.
Sequestrectomy.
Ye dekho.
First you have to find the sequestrum, no?
Sequestrectomy.
Barabar. So it was going up to the fracture site. So traced up to the fracture site. And then take out the sclerotic bone. And underneath that, you will see the sequestrum. Not just that. This is the
Pus there.
large area of dirty granulation tissue, which is sort of become semi-solid because of several antibiotics given. So you take this off. You also have this granulation tissue here, which corresponds to your osteolytic area. ये देखो इधर, बराबर? And then this is after a thorough debridement. Now, what do you notice here? After debridement, I have taken out the sequestrum. I have taken out the granulation tissue. I have scooped the proximal and distal portions. I widened these holes. Now what do you see here? That's the fracture site. What do you see here? So part of the bone seems to have healed, isn't it? And distally तो अच्छा है, जुड़ गया है. Correct? And this is what is after the surgery. Now what should I do? I have valgus. I have, yeah, if you can discuss this, what will you do? And A, what do you find?
So cement spacer, antibiotic cement spacer.
I am talking about the alignment of the bone.
And externally fix the bone for external fixation. The line.
So will that change the
Sir,
alignment?
no.
So are you
Sir,
accepting this
valgus is
alignment?
acceptable because it is less than 5 degree, I think. And but we have to correct this anterior angulation, recurvatum.
You
Anterior angulation is recurvatum.
No,
No,
sir,
posterior
posterior.
angulation is recurvatum.
Procurvatum.
So are you going to accept this alignment or you're not going to accept this alignment?
Valgus we can accept, but recurvatum,
I'm asking you a very simple question.
no,
Are
sir.
you're not going to accept this alignment? Yes or no?
No,
No,
sir.
sir.
So it's a union fracture that's united. So you're going to cut it and break it and then correct the alignment.
So exactly what procedure you will do to correct the alignment?
Osteotomy.
Osteotomy of the
No. I will do this Elizaro ring application.
say
how
how will
much-
you correct the angulation?
How much recurvatum are you willing to accept?
And 5 degrees, 10
How
degrees.
much? So if it's 10 degrees, this is acceptable, isn't it?
And there is two
But
sides for
suppose
this.
you decide not to accept this, then what will you do? You put Elizaro, लेकिन the fracture is already united. बराबर क्या नहीं?
Yes.
So
Yes.
what will you do? So what will you do? Adish
Yes, sir.
Jain, bolo. You suppose you decide to correct this angulation. Suppose it is 25 degrees. You decide to correct it. How will you correct it?
Sir, if it is 25 degrees, we have to correct it.
How? I'm just saying that suppose it is 25 degrees. How will you correct it?
Can we do, sir, do nailing?
Nailing will correct it. I mean, you have to do an osteotomy first, na?
Yes, sir.
And then what else?
Your tibial osteotomy and something else. Something else.
Tunnel fixator application.
External.
Fibula
Anything
united?
else?
Is the fibula united or not united?
It is united.
So will it stop you from correcting the tibia?
Yes, sir.
Yes.
Yes,
So
sir.
we have to perform a fibular osteotomy also.
You have to.
Right. Correct. So we'll need fibular osteotomy. Another incision in an infected scenario may compromise future soft tissue reconstruction and is already diabetic. And he has a good union distally and semi-union proximally, correct? In a diabetic, I thought I will accept this.
Yeah.
Now there would be would be two opinions about it, but then I felt कि I'll play safe. Correct?
Yeah, because anything you is not always only based on angles, okay? You have to see the patient factors also when you make a decision, okay? Post situation, what the morbidity of surgery is, all those things you have to take into account when you're planning your treatment. So
Now
maybe
sorry.
yeah. So maybe in a situation in a young patient where you would correct it, in an older patient with diabetes and other comorbidities, you might decide to accept the angulation where the fracture is healed or appears to be healing. So you've already got some element of stability. So you don't need to further do anything to stabilize the fracture. Okay, so all these things have to be taken into account in your decision making.
So the same culture pattern. He was treated with cefazolin and oral cephalexin for 4 weeks. Then, as we decided, getting a closed envelope is important. So this was closed. I could close this part, I could close this part, and then a flap was done to cover this. And here we have put in a cement, vancomycin with PMMA. Why? Why have we done that?
Will make induced membranes around it.
Perfect.
What was the reason I gave? What's the first principles of treatment is elimination of dead space. Okay. So the cement also eliminates dead space.
Yes.
Right? So elimination of dead space. And the areas where we were not going to revisit, like upper and lower, we inserted stimuli. So that is post-op. So we removed that and put a graft at 6 weeks. Anything else you would like to do? Can you describe this fixator?
This is tape protein.
Can you describe this fixator?
1, 2, 3. Patterns.
Sorry?
Sorry?
sir.
So what kind of fixator is this?
This
So once
What
you-
it's a simple tubular external fixator. You may put it in different planes, that's up to you. But here the planes are really determined by the fact that you want to avoid the areas where you are going to do a soft tissue cover.
modular.
So it should allow you flexibility to take your incision or do a plastic procedure. समझा क्या नहीं? That's why they are inserted in different planes. But then you use rod to rod clamps so that you can connect them and create a good frame, right?
So what you do for damage control is what? Modular fixators. Simple fixators which you connect in
You can
different
put
directions.
wherever you want. Put shank screws wherever you want and put rod to rod clamps and connect them. Now, what is LRS? Any difference between this and LRS?
Yes, sir. LR is the limb reconstruction system which work in only one plane, sir. With this fixator, we got multiple planes.
Very good, very good. Any difference in the shank screw size and the type of shank screws, anatomy of shank screws? So the LRS has tapering shank screws. 5.5, 6.5. Okay.
Advantage, disadvantage. Yeah.
It is very advantageous. Okay. So this is 6 months post-op. Are you happy with this, or you would like to put more grafts here?
It is uniting in 1, 2, 3 cortex almost, sir.
So will you put graft or you will not put graft?
Not going to put graft, sir.
Are you going to protect the limb?
Sir, almost more than 50% cortex is present, sir.
Are you going to protect the limb? Simple questions. Why don't
Protect
answer
the
something else, okay? I don't want to know 50% or 40% or 33% or 52%. Huh?
जो करते हो बताओ, यहाँ पे देखे तो इतना क्या करते हैं एक्सटर्नल फिक्सेटर रिमूवल के बाद?
Sir, cast करते हैं.
Right.
Put a cast, but any option for other alternative?
Sir, patellar tendon bearing cast sir देंगे sir.
Cast है, caliper भी होता है.
Yes,
sir.
Okay.
Molded caliper, you can contact.
Yes.
Contact brace you can give. Barabar? They take measurement and prepare a brace, correct? So what is likely to happen here? You think he'll have to be protected all his life? Because the diameter here is much less than the normal diameter, isn't it? We have a big void here. So almost 1/3 area is not there. Correct?
Yes.
So will you need to protect him all his life?
No, no.
Yeah?
No, sir.
How much of
Why
his
not?
life? So how much of his life are you going to protect?
Up to, sir, 6 to 7 weeks, we put, sir, 3 months,
6 weeks.
sorry, 6 weeks. Then weight bearing, visual weight bearing started so that the bone get formed for the.
You won't start weight bearing straight away.
करवाओगे इन्वेस्टिगेशन भी देखने के लिए?
Yes, sir. Sir, regular X-ray for follow-up and sir.
So you think this bone is going to form over time? It's going to hypertrophy over time? Or you're going to have to put more grafts, or what do you think?
Is there any law?
Yes, sir. Wolf law and.
Correct. And then there is a very nice paper dated 1990. Say, my Dr. Kothari was my professor. After cadaveric experiments, he proved that bone is not attached to anything. Bone is like air in a tubeless tire. It supports the soft tissue envelope, but takes the shape of soft tissue envelope. So if you have created a soft tissue envelope up to here properly, the bone over a period of time will take that shape. समझे कि नहीं? Suppose there is a slit in between your envelope, then the bone will form on either side of that. So it takes the shape.
Soft tissue, okay?
It takes shape of the soft tissue envelope. Now here we have used a flap so that we have adequate space there, good envelope. So this is 1 year after debridement. You can see the envelope is filling up. This is at 20 months and this is at 30 months, 36 months. So here you can see over a period of time, the envelope is filled. Correct?
Yes.
So this is after 3 years.
So what is the take-home message? Now I want you guys to tell me what is the take-home message from this case. What did you learn?
one point for it from everyone. Subanshu, you start. Unmute. Unmute yourself.
Yes.
It's just 1 point.
Sir,
Take
while
home.
seeing this X-ray, we have to also look, matlab zoom out X-ray we have to see in infected cases.
Okay. So one
Zoom out
is
X-ray or zoom in X-rays?
Zoom in, zoom in.
zoom in.
Okay.
Okay.
Sachin.
Then
Sachin.
Sir,
Yeah.
we have to properly eradicate or remove the infection before doing any intervention for further. I depend on the stability and the
Okay.
culture bacteria, what kind of bacteria, so can we apply proper antibiotic.
Debridement, adequate debridement, yeah?
adequate debride. Okay. Now here I would like to tell you about a chapter in the book, which is by British Orthopaedic Association and British Association of Plastic Surgeons. They say that there is nothing like debridement. They have deleted the word debridement and they have started using the word excision and extension. They say that you have to excise the infected wound or contaminated wound. But if you want to see it from all sides and excise it properly, you have to extend on either side. So it is debridement actually should be called excision, rather excision and extension.
Don't you
Then
think that's
you
just,
put that into your mind, then you will realize that this is what you have to do.
that's just a play on words, isn't it? But
Yeah, but then that actually gives you the proper meaning.
yeah,
The
but I
reason
mean,
is,
when you
the
debride,
reason is
hang
that
on, but when
I have seen several people who in open fractures also, they don't extend the wound. They
I know, but
just,
that's basic teaching. No? When you do this, you have to extend the wound. I mean, I just feel that just to put words there is really something.
in fact, I tell you, in one of the meetings, I said this, and somebody from the faculty challenged me. He said, that means you want to convert grade 1 fracture into grade 3 fracture? Why should you extend the wound?
So
that was from a well-known faculty. So that is why I thought this is a very important message, that you excise the wound and extend the wound.
Okay.
So,
Anything else?
yeah. Thank you very much, sir. I think
Oh,
Let's finish. What else? So what are the
that
other
culture
things?
report,
Okay.
reading of culture report, sir.
Okay, fine. What else?
Culture.
What are the other things that you've learned here? Soft tissue cover, okay?
So soft tissue proper envelope will heal the bone defect after some time.
And dead space elimination. Okay, so these are the basic
Dead
principles
space.
of management,
Right.
elimination, whatever you like to call it. Okay. And stability. We haven't
Stability.
talked about stability.
stability.
So if you remember these things, then you can plan your treatment for infection without knowing anything. Okay.
Okay.
Yes, sir.
Chalo, we call it a day.
Yeah, I think so.
Thank you, sir.
It's
Thank you
almost
very much, sir.
8 o'clock.
Okay.
Thanks a lot,
Bye-bye.
Vikash, as usual.
Bye.
Very
Bye. Bye.